That's good. Mr. Henry, thank you very much for joining us today. Again, we look forward to hearing from you and maybe having the opportunity to ask you a few questions if you don't mind.
Wonderful. Thank you for the opportunity to speak with the Commission today. And first, I want to thank you for your efforts to protect all of our citizens through safety actions you've put in place and by having a real vested interest in monitoring the numbers so far. I think that's really important for our communities. This has been a very long response already. We're entering into the 10th month of active emergency response related to COVID-19, and I believe we probably still have 4 to 6 months to go, depending on how quickly the vaccine rolls out and how effective that is, which may depend on how many people take the vaccine. So still a journey ahead of us there and lots of work. And I think most important as we continue down that road is to help keep people focused on those things that protect us now until a vaccine is available, which includes the social distancing, masking, staying home when we're sick, and enhanced sanitation, hand washing. So those things remain critically important and will be important for several more months. I did want to talk, I have had a number of conversations with Mr. Harmer on the data and what that looks like and the state database and some of the limitations that we have for pulling that information out. The data, when cases are reported, auto creates a case and the computer assigns the case to a zip code and a county based on the information in the case. And what we found over time is that for the Longboat Key zip code, and you're kind of unique in that you have just one zip code for your entire town area. In fact, I think that's unique in Sarasota County for sure. I think the city of Sarasota has one zip code that's all city of Sarasota, but all their other zip codes are partial city and partial unincorporated areas, so it makes it difficult to sort out as well. But in your case, you're split between two counties, and so what we found over time is the system more often than not assigns the cases automatically into Manatee County. And once that happens, we can go in and look at the cases and see them. And if we look at the address and verify that that address is really a Sarasota County address, we can communicate with our partners in Manatee County and ask them to go in and manually change the data for us. We're not able to do that unless the case is assigned to Sarasota County. So it creates a little bit of a workaround. We're trying to make that work by pulling going into the system manually and downloading all the data we have for both Sarasota and Manatee counties, looking for new cases there. And if they're incorrectly tagged to a county, we reach out to Manatee and ask them to correct that. As you see this time in the heat map, that did generate 2 new cases on the Sarasota side. One of the problems with that over time, and so I'm not sure the bang is worth the buck, so to speak, is that by the time we contact them and ask them to change things, and they get in and change things, and then we can pull the data and make the data available to our emergency operations center that creates the heat map. We're already 3, 4, 5, 6, 7 days out, and some of the cases start falling off. As I did this morning, I can query the data and ask for any cases that were newly reported in the last 14 days. But then we have to look at each of those cases and see when did those cases, even though they were reported in the last 14 days, when did the illness start and are they still in quarantine period or not? So there's a difference in reporting, total cases reporting, and the number that are still in active cases or actively in isolation because they have a potential to transmit it. So it becomes a little bit more complex, but we will continue to try to work to look at that data and try to keep Mr. Harmer and all of you informed in terms of what's happening on the island as we move forward. Let me talk about contact tracing just for a minute, and then I'll stop and certainly try to answer any questions you have. That's a pretty straightforward item. Contact tracing is done by the health departments, for your island, both from Manatee and Sarasota. We make every effort to begin the initial investigation within 24 hours of receiving notice of a new case being generated. And then that initial investigation will identify potential contacts from that case. And then we try to reach out to those contacts within 48 hours of that initial investigation. That's true for Manatee County as well. That's just the standards that health departments try to work towards. Sometimes we're very successful in that. Other times, if we get 200 or 300 cases in one day, it's a struggle to complete all of those cases and all of that work. We do have access to a statewide vendor if we have those days that are really high numbers that we can move cases to, and they'll make the calls for us and complete that work and help us ensure that we're trying to contact everybody. It's just that's not our preferred way to do it. We'd rather reach out to individuals in our own county and work with them because we can understand better where people are at and where they've been within our own community. So that is the contact tracing process. There are some things that slow that down. One of the largest ones is the amount of time it takes sometimes for us to be notified of the case. There's many testing venues now available aside from the large state-run sites at Cattleman Road and R.L. Taylor. Drugstores offer testing, private providers are offering testing, urgent care centers are offering testing. There's even some mail available testing, but in the end, the results, if they're positive, have to be entered into the statewide database, and then it gets reported to us. And the law does require all labs to enter those in, and so the labs are really good about that. But with a PCR test, it's typically a 2 to 5 day delay from the day that they were tested till when the results actually show up in our system. And then with the rapid tests that are being done not only at the state sites but by many of the providers across our community, it's up to that provider to report those to the Department of Health, and there is a reporting portal that they should all be utilizing. Although we still sometimes get faxes from providers, but many times those are batch faxed 3-4 days after the tests, and that slows down our ability to contact people and follow up on the tracing. So I think everybody and that is working very hard, including all of the providers that are providing the testing. It's just a lot of work around, and so I share those insights into the testing process and contact tracing just to make you aware of them, not to certainly criticize anybody because we have our own struggles trying to cover all of the work that needs to be done. I'll stop there and try to answer questions on that before we move on to vaccines.
I see Commissioner Bishop. Go ahead.
Thank you, Your Honor. Mr. Henry, thank you for joining us. As you talked about contact tracing and you've talked about the difficulty with our zip code, I'm wondering how you contact trace when you're not accurately able to identify where the cases are on Longboat Key between Sarasota County and Manatee County. And then my second question, which I think has more to do with policy than logistics. Our island during off-season is 7,000. During season, we increase to somewhere between 25 and 30,000 with snowbirds, monthly rentals. So those are people who are here for extended periods of time, but because they are not, quote, residents of Florida, I understand that if they are tested positive, they do not reflect in any of the numbers that we receive, and therefore we're not on top of how desperate the situation may or may not be out here.
Those are great questions. Let me talk about the first one. When I say there's challenges with the database identifying whether the case is in Manatee or Sarasota, the cases all have addresses attached to them. The system doesn't always recognize is that address in Manatee or Sarasota, and we found it more often just assigns it to Manatee County, but the address is the address. And so whoever the contact tracer is, whether it's the Manatee office or the Sarasota office, when we talk to them, the process of contact tracing is to understand, first to verify the facts of their illness, and then to understand from them, directly from them, who they think they may have been in direct contact with the 48 hours before they became ill, or the 48 hours before they had a positive test if they were asymptomatic. And those are the individuals we then try to reach out to and talk to in terms of our work with direct contacts. And so that process should happen with the index case, regardless of whether we do it, Manatee does it, or the statewide contractor does it. So it should still be effective. It's not a matter of not knowing where they're at. It's just a matter of the system not assigning the county code correctly. And so that's what we're working with there. On the second question, that certainly applies to Longboat Key. It also applies to the rest of Sarasota as well, some areas more so than others. We all have a huge seasonal influx, and you are correct. If an individual does not have a residency in Florida, then the state will put those in the out-of-state category in terms of the numbers that they report. The only way for us to really track those down is to look at all of the out-of-states that were diagnosed in Sarasota County and go through our contact tracing process with them. And so we still try to reach out to them with initial interviews to understand, are you still in Sarasota County? Are you visiting for the week? Are you a temporary resident here for a period of time? And if so, where are you at? The challenges with capturing that data for a heat map is that data is put into the notes from our contact tracing team and interview team. It's not a data field that I can search in the database. So what we've been trying to do on our side is when we have out-of-state assigned to Sarasota County in terms of what county they were in when diagnosed, we look at those cases, we go into the notes from the interviewer and try to determine where are they at. And we've been trying to capture those and reflect those in our 14-day heat map, just to help out from a planning purpose and to understand where people are at. I think it's important to know.
Is there any way that we can see those numbers of what's here that are non-residents?
Well, I can try to make those numbers available to Mr. Harmer, and we've been trying to look at that at least on a weekly basis and report those out. I can tell you because in preparation for this meeting, I looked at the database this morning and looked at those cases from the last 14 days. There were probably just over a dozen non-resident cases in there, and I looked at each one of those and could not identify any of those as a current temporary residence on Longboat. That said, out of that, I think there were 13 actually. There were probably 4 of them that there was no information on where they were at. So I couldn't tell you on those 4, other than their test was positive here in Sarasota County at a test site, whether they were just passing through or more temporarily here, and if they were here, where. So it's not a perfect system, but it does try to capture as much information as possible. And I should say sometimes those are gaps because the numbers that we have for individuals don't always get answered, or people don't call us back. And so while we're aware that there's a positive case attached to that individual name and phone number, until we talk to them, we can't gather the information we need to complete the work.
Commissioner Daly.
Jack Daly, the numbers today show substantially increased hospitalization activity. And there was an article in the local Sarasota Trib today focusing on that. and the like, expressing some concern. Just generally, if and when there is a need for reactions and restrictions at hospitals such as the Sarasota Memorial Hospital, by way of example, to take some action in response to increased activity. How does that decision, how is that made? Is that a county decision, a hospital decision, or is it a collaboration towards developing a plan to respond to it? And just generally, what are the criteria for those decisions?
So another great question, and thank you for that. The hospitals themselves all have emergency plans in place and have for years, and we work collaboratively both with them and Sarasota County Emergency Management to understand hospital capacities, whether it's to handle an emergency like an explosion somewhere with lots of injuries, or a hurricane, or in this case, a pandemic event. And generally speaking, the decisions to move into various levels of emergency phases in implementing the plans are a hospital decision based on what's happening within that hospital. Obviously, if the county emergency management system feels that we're moving more quickly to crisis and the hospitals aren't reacting, we'll be discussing that with them and work collaboratively towards implementing various parts of the plan. And that's generally how it has always worked. Although earlier this year, you saw in preparation for the unknown, at the state level, the governor directed hospitals to stop elective surgeries and to decompress or discharge as many patients as possible to create space, which happened in the summer. And now hospitals are operating back at normal. And that certainly is part of the concern right now. Overall, the COVID numbers are not dramatically high, but when you put those in context with we're in the beginning of season for our area of Southwest Florida, and in season, all of our hospitals are normally at 80 to 90% capacity in normal times, then the ability to stretch without implementing emergency plans can be challenging. It's encouraging to me that right now the numbers in our ICUs across the county are remaining relatively stable. And I think that's a direct function of two things. One, more tools for us to treat COVID with as we learn more about it. And two, more experience of our medical staffs in the hospitals in dealing with patients and having a clearer understanding of what's needed and what's not needed. Numbers have begun to climb. In fact, today's numbers are about 140 COVID-positive patients in our hospitals, 4 acute care hospitals. The majority of those at Sarasota Memorial, and so we do watch that very closely. And in comparison, in mid-July, when we hit our peak so far in this pandemic, the high was 165 COVID-positive patients in our hospitals. And at that time, we had a much higher number in the ICU, which was our biggest concern. You saw that ICU number of 114 as the capacity for Sarasota County. And I will tell you that number could be expanded significantly if the hospitals needed to. But expanding those ICUs means stopping other services, because that expansion happens by taking other surgical procedure rooms and turning them into ICU beds because they can isolate those rooms and equipment. And the space is generally not as big an issue for us or the equipment as staffing is in our community right now. This is the time of year when many of our hospitals plus up their staffing to meet the normal demands by using part-time staffers from a number of different agencies. And as you might imagine, part-time medical staffers, especially with experience in ICUs, are at a high demand nationally right now, and there's a shortage. And so that means that we're always watching the numbers every day and talking about them with our Emergency Operations Center, and when necessary, having conversations with the hospitals. I can assure you when And the hospitals get a number of admissions, maybe coming from a long-term care facility. They don't hesitate to pick the phone up and call me right away to see what's going on and what we can do to help limit those and make sure only those that need to come to the hospital are being hospitalized. So we do stay in close contact.
Thank you.
Vice Mayor Haycock.
Yeah, Mr. Henry, thanks for joining us today. I've known a couple people that have had false positives on the rapid test where they got tested negative and then a couple days later got tested positive, then a couple days later got tested negative. Can you speak to the accuracy of the testing and any guidance around, if you do feel like you need to be tested, what type test should you take?
Sure, I can try to do that. First, let me say I'm not an expert in all the testing science, but from basically most of the rapid tests are an antigen test. They're looking for antigens of the virus, and maybe the simplest way to put it is the window for antigens to appear in large enough numbers to be detected is a smaller window than with the PCR test. The PCR test is based on an RNA genetic test, and so it's looking for genetic evidence of the virus. So the genetic test is much more accurate and much more sensitive, and probably is up in the 95 plus reliability range for individuals, whether sick or well. The problem with the antigen test, one of the problems is the emergency use authorization was primarily for use on individuals that were ill, because when someone's ill, they're more likely to be in that more narrow window for enough antigen to be present to get an accurate reading. And so they're pretty accurate with positives, but it's not uncommon to have a negative antigen test and then several days later, if you were to go back, have a positive antigen test. Likewise, you could have a positive antigen test, which probably means you had the COVID virus, and several days later, you would have a negative rapid test because that antigen window is closing. But if you did a PCR, you'd probably still pick it up. So they're both really good tests. The antigen test for individuals that are currently experiencing symptoms is probably 85% or better in terms of accuracy, but that accuracy can drop to 70 or lower if it's used on well people all the time. That doesn't mean it's a bad test. It's a great additional tool for our testing arsenal. It still helps us identify illnesses and quarantine people more quickly than perhaps with PCR, especially when the labs were backed up.
Okay, thank you.
Chuck, a couple of questions. To follow up on something that Commissioner Bishop was asking at the outset on long-term, on seasonal residents, and focusing on long-term seasonal residents, I can understand why it's difficult to place in Sarasota or Manatee County someone who's staying at a hotel or maybe a week at a timeshare. But so much of the population here during the winter are people who are here for 2, 3, 4, 5 months from somewhere else in the country. Do those people not indicate when they are being treated and they're determined to be infected that they have a long-term local residence that could then be counted in the numbers in some fashion, even if that has a subset?
Well, I think probably more often than not in our healthcare system, the system demands the permanent residence address and billing address, and that's what gets captured. And it's not until we reach out with our case investigation interview that we ask the questions, why are they in Sarasota? Why were they tested here? Do they have a local address? They're staying here, and for how long? And who might their contacts be? But you know, our system as a whole generally will capture the permanent billing address for an individual when they engage our healthcare systems, and that's one of our problems in this particular pandemic.
And on that score, and this is for future reference, but whenever you go into a doctor for the first time, even if you're just filling out a 2-page form, they want to know what your permanent residence is, but they also want to know what your local residence is. So it might be something worth thinking about capturing going forward at some point. One other thing, we now look like we have 97 cases between the two counties on Longboat Key, a lot higher than we were thinking we had just a month or two ago. When this started, when someone was infected, people on the island knew who it was. We're a small place. Most people know at least a large number of people who live out here or even visit here. So we knew who was infected. We knew where they got it. We knew which party it came from, down to the person, not 100%, but 90%. With this new much larger number, we're not hearing any of that. And I don't think anyone on this commission is hearing a lot of anecdotal reports of people who are infected here. Can you explain why that might be? Are people just being more quiet, or is it possible that the 97 isn't real?
I believe the 97 is real, and I can certainly pull a report from the beginning to go back and verify that and report that back to Mr. Harmer if that's helpful. I can't explain why people would talk or not talk. Obviously, as a health official, we can't disclose any personal information on cases beyond how many are in the various zip codes. And I think it's important when you talk the 97 number to know that that's cumulative since the 1st of March moving forward.
Right.
The numbers I pulled this morning indicated 7 current cases that I call them active cases, meaning they're still in their 10-day isolation period that currently exist on the island.
And one last question. We hear a lot of national and statewide news, not so much that we hear that's local. So from the local area, Sarasota, Manatee, have you been able to figure out from all the information you've collected what in our area are the primary causes of infection or clusters of infection? And with that information, what more we might be able to do out here to try to protect ourselves better?
That's another good question. And right now, we have the occasional what we would call outbreak clusters, whether they're in a facility or around a certain place of business that we work through. But by and large, I would describe our cases in the Sarasota area as widespread general transmission, meaning they're occurring across the community, but are really difficult to trace back to a single incident or event. As Mr. Harmer noted, our percent positivity, which is simply percent of positive cases versus total tested, last week was around 6%. It has been beginning to creep downward in the last couple of weeks before Thanksgiving, and so we've been watching it closely this week, waiting to see if there's an impact from Thanksgiving back the negative way. We haven't seen that yet with the total numbers in terms of percent positivity and cases per 100,000, which is another piece of data we watch. We have seen an increase, as you talked about earlier, in our hospitalizations, which is concerning. The other piece we watch closely is the average age of those being tested and the ages of our positives. Initially, when this pandemic first started, say March through July, the average age was pretty high for Sarasota County, in the low 60s or high 50s. As we got into July, through late July and early August, it dropped to about 45. It climbed back up now cumulatively to about 48. Yesterday's, we got about 2,300 total tests in the last 24 hours. 106 or 107 of those were positive, which in the average age on that whole group was 47. So That's just another area we watch to help us understand where illness is occurring. We have teams that are in the schools and in our long-term care facilities watching those institutions and what's happening. And actually the schools have done fairly well considering the 40,000 or so students we have. Their overall number of cases is slightly less than that across our broader community. So we're very pleased with where that's at.
Yeah, thanks very much.
I do think
Commissioner Bishop again?
Thank you, Your Honor. Just one question, Mr. Henry. One of the things that obviously causes concern as we get into these higher pedestrian traffic seasons, we see clusters of people on St. Armand's walking outside, few with masks on. Last week in the Herald Tribune, they were promoting the pub crawl on Siesta Key with hundreds of people without masks on. And as a state, we seem to be doing a lot of advertising and promoting, come to Florida, it's holidays and warm weather. And I'm wondering what the PR campaign is on the other side from your office and other health officials to get those types of events not happening, and certainly trying to protect those masses that show up in those environments.
so. Another great question. First and foremost, as a public health entity, we don't engage in the marketing aspects for tourism. What our role would be is to encourage anybody that's here, regardless of why they're here, to follow safe practices. So we want to continue to encourage masking and social distancing, hand washing, and as you already articulated, not every group that is around our community, whether they're from a local address or visitors, follows those processes, and therefore that's why we continue to see widespread community transmission, staying in that positivity rate of 5 or 6%. That's not going to go away without more people following all of those procedures. At the same time, in addition to the pandemic side, there's the business side and the issues with the economy, and trying to strike a balance that protects our community and allows commerce to occur. And I don't know where that sweet spot is, so to speak, and nor does anyone across the nation. And we see a lot of different approaches in different ways that are taken by leadership at local and state levels. My role on the public health side is to take whatever direction that is and to try to do the best public health job we can with whatever those policies are.
Are there any other questions for Mr. Henry? Seeing none, let me thank you for your constant communication with our community, mainly through Tom, and you're visiting with us from time to time to explain to us what's going on. We appreciate your help. Tom?
Mayor, if I could just, I think one more thing that I would ask Chuck to hit on before he leaves today is his understanding of what the program may be in Florida for the distribution of vaccines when they become available. If you don't mind, I think it'd be helpful for him to touch on that.
Well, happy to do that. In fact, I had said earlier that I would circle back to that. So there's still a lot of information being developed on exactly what the rollout will look like. But as most of you are aware, this Thursday on the 10th, the FDA will be looking at, the formal committee will be trying to make a decision on the Moderna vaccine, which is one of the early ones in the approval pipeline. It's anticipated that it will be approved, and that will be under an emergency use authorization like many of our COVID tests are. If that occurs, I would expect to see vaccine distribution begin in the state of Florida the very next week in a limited capacity to, I think there's 5 hospitals that have been identified, large hospital systems that have the appropriate storage as an initial distribution effort, just to exercise that system, follow closely based on any lessons learned there with distribution through a network of quite a few other hospitals that have super cold capability. That particular vaccine requires storage in a negative 70-degree freezer environment, and so it's shipped on dry ice and has to be stored appropriately. So there's some supply chain limitations in terms of how that's distributed. But in the early part, when I look at prioritization in the state of Florida, the early top priorities are going to go to hospitals that are caring for COVID-positive individuals and to long-term care residents and the staff that work there. Those are the priorities for the very first vaccines that go out. As more vaccine becomes available, it will continue to be made available to other healthcare workers, first responders, and those with underlying health conditions and risk factors, which would include anybody over 65. And I didn't talk about some of our local data on that, but I think it's really important to recognize that 76% of the deaths that we've seen in Sarasota County have been in individuals over the age of 75. If I drop that age to 65, it's 96% of the deaths and 75% of the hospitalizations. So clearly, our long-term care community and those over 65 and with underlying health conditions will be a priority group that we want to get vaccines to as soon as the state plan allows. And I'll be reaching out to Mr. Harmer and your public safety team to talk about the best way to do that for populations on the island as we move forward and understand better what the timelines for distribution to those groups will be.
Thanks. Commissioner Daly.
Just a follow-up with respect to underlying health conditions for elderly residents. How will that work generally? Is that through self-identification, or what kind of criteria will be utilized in that category?
Well, I can give you my best thoughts on it.
Okay.
And those, you could get some directives from the state that may change that. But generally speaking, as we roll those out, I think there'll be a questionnaire that says, are you over 65? Do you have some of these conditions? And ask people to affirm that to get in line for the vaccine. Hopefully, there'll be other vaccines approved shortly after the one being considered next week. And the availability of vaccine, especially as we get into January and towards the end of January, we'll have plenty of vaccine around to move to a number of priorities more quickly. So I envision at some point there being, as the plans roll out, there should be vaccine available from private providers, from urgent care centers, from clinics run through the health department, through a number of pharmacies. So just like the flu vaccine that's widely distributed today, the goal would be to make it available to a number of venues so that anybody that needs it can get it.
Thank you.
Thanks very much. I'm not seeing any more hands raised. So again, thank you very much, Mr. Henry, for visiting with us and explaining how things are going. Good luck with the what you're doing, and we look forward to the vaccine.
Thank you for the opportunity. Have a good afternoon.
Our pleasure.